Good thing we have Courtney for editing. Okay, quarterly training. I forgot one thing. So, a couple things. I sent out the medical minutes. If you guys didn't get them, I'll email you a copy here in just a little bit. You can review them this round. Let me know if you have any questions. Has anybody had this already before? Oxytocin? No? Wow, okay. Usually on the last day of training, I've got like multiple times. Okay, so a couple things that are in the medical minutes, but we need to just mention again, is anybody in the current period where they are expiring on the 31st of March? Just one? Did you get an LMS assignment? No. Did you delete the LMS assignment as soon as it got assigned to you? No. Okay. If you expire March 31st with your national, you will have gotten an LMS assignment October 1st. Okay. Sean, you've recertified with us before as an EMT, right? First time as a medic, same process. Okay, you've got your voucher information in there and that kind of thing. Okay.
2 more hours.
Okay. Yours will be coming due, I believe, next summer, because I think it's a 2-year deal, right? And you certified, did you certify in June?
June.
With the other recruits? Okay. As an EMT? Yes. Do you not remember back that far? You look very confused.
That's when it happened.
That's when it happened.
Yeah.
Okay. When you get your LMS assignment to recertify, do not delete it. Okay, it's got all of your information in there, including a voucher number, and you need to have at least a 3-week buffer before your actual expiration date to make sure your stuff is in. Because what happens is people will auto-delete the LMS assignment, and then the 28th of the month they expire rolls around, and they haven't done it because it's off of their list. And then the 1st of the next month rolls around, like April 1st, if you expire March 31st, you are no longer licensed. And you have to have a license to work here. Read between the lines on that, and you get a nice little bit of some time off with no paycheck and some paper to go with it. Okay, so medical has not been sending out CAPC assignments to you guys for probably 2 years now. Okay, with all of the in-person stuff that we do, between my stuff, between Bjorgi's case reviews that he puts together with the hospitals, between Dr. BZ's quarterly updates and tacos with the doc and stuff at St. Mark's and whatever, very few people in operations have actually had to use CAPC hours in order to fulfill their requirements to recertify. Okay. If you need CAPC hours, everybody still has access to them in the library. So you go into the file center, type in CAPC in the search bar, and it will pull up everything that you need. So if you need like an hour more of airway, you can select what airway assignments you want to look at, okay? But don't procrastinate. The state has come out and said that they're going to start merging national and state expiration dates. So you will expire on the same day with both licenses. They haven't told us the exact process of how it's going to happen. I know that some people have received emails already from BEMS saying that they now have one expiration date that covers both their state and national. Okay. Anybody in here gotten an email?
I got that one.
You got? Oh, that's right.
This last renewal, yeah.
Okay. So you've gotten yours. They haven't told us like by what point that's going to be all done or anything like that. So just watch for that email. Okay. All right, Power DMS, a little update here. We know that the app is having some issues. It's crashing frequently. We're working closely with Bill Brass, who's working closely with Power DMS to try to fix that. We have a request in with them to get the app to work offline. So if it crashes or you're out of cell range, you can still have access to the protocols offline. If the app crashes, you will still have access to the web version. So you can go into your browser. On the UFA employee webpage is a link to Power DMS. Okay, you can use it on the tablet, on the ambulances and stuff like that. You'll still be able to access the protocols. We've got a pretty big project in the works right now. I'm not sure when it's going to be finished, where we're consolidating a lot of the protocols together. Most of these protocols start out with treat the patient according to universal patient care, assess the airway according to airway management, evaluate breathing according to, so on and so forth. And we don't need to have that in every single protocol. That is universal patient care. BSI is Mycene Safe, A, B, C, D, E, okay? We're also fixing where like you're looking at one protocol and it references you to another protocol and that references you to another protocol, which then references you back to the original protocol and you still don't have your answer that you're looking for. So that's being fixed, okay? Yeah, it's a pretty big undertaking because there's lots. So the protocols all blur together and I'm not even doing most of the work on this, okay? In the meantime, they've created indexes for us in Power DMS. So under the protocols and medication references, the very first document that you see is just a quick list of all of our stuff. You can click on any of these and it'll hyperlink you over, okay? Yes, we are fixing the typos that are in there before my OCD is like, it's not working, okay, but we're fixing those. All right, this is in the medical minutes, but we're going to talk about it still. I know we've talked a lot in the past about your dispatch information versus your chief complaint versus your primary impression, right? I think it's going to be a conversation that's just a rolling conversation all the time, which is fine, not a big deal, okay? Remember that your dispatch information, your patient's chief complaint, and the primary impression are oftentimes 3 totally different things. Your impression is your differential diagnosis. It's what you are tailoring your treatment towards. So you get dispatched out on an unconscious person. There's no chief complaint because they're unconscious. You can leave it blank. It's a free text field and it is not required, okay? You do a blood sugar and you find out their blood sugar is 20. Treat it, they wake up. What's your impression? Hypoglycemia. Okay, it's not unconscious, it's not syncope, it's not altered mental status, okay, it's hypoglycemia, okay? So you also only need to have one impression to close your chart. If it's cardiac arrest and you're frustrated because you can't find a secondary impression in order to fit the call, I've seen some really creative stuff, by the way, you don't have to have a secondary one unless it applies. So the unconscious person that we were just talking about, let's say when they passed out because their sugar was 20, they put their arm down and broke their arm, okay? They've got a deformity in their arm. Now they have a secondary impression. What's their secondary impression? Trauma. Or injury, right? We don't have things like abrasions and lacerations and that kind of stuff. Those are signs and symptoms of their injury, but it's injury, okay? So a secondary impression isn't necessary unless it applies. We've had some full arrest calls that have come through where the crews worked the patient on scene and then before they have signed this scene over to PD custody and stuff, they've classified those instead of a cardiac arrest, an obvious death. It makes sense because the patient is obviously dead at that point, like y'all did your thing and they're super dead, right? But remember that your obvious death impressions, those are the patients where you walk in and you're like, ooh, they are part of the carpet, okay? They're missing their head. They are stiff, they're cold. We're getting into that season where cold isn't quite as reliable as during like the summertime, but you know without a doubt that they are dead, okay? Now keep in mind that obvious death and injuries incompatible with life are 2 different things. So we actually made a small edit with the determination of death protocol for copious amounts of brain matter on the scene. Not compatible with life at all. Doesn't mean that they're dead right there, okay? There's an agency in the Midwest right now that's in a little bit of some hot water because they responded to a guy who shot himself in the head. PD got there, made sure the scene was safe, let EMS in, and they looked and went, and there's gray matter all over and whatnot. They didn't even touch the patient. 8 hours later, after the crime scene techs were like, we're done, what do we do with this guy? Because he's still breathing. Okay, not compatible with life, but he should have been patched up and taken to the hospital, okay? And just a small side tangent for a second, we do not document that we transport anybody for donor services. We don't transport for donor services. We transport for level 1 trauma criteria. Make sense? I know that that's in our minds. We're thinking that, okay? But our documentation is level 1 trauma criteria. We're taking them to a trauma center, okay? It gets really, really sticky when you start messing around with, oh, well, I think this person's a candidate for donor services and that's why we're gonna transport them here, and don't do that, okay? All right, you guys are actually one of the best crews at capturing asystole on your patients, that before you call it, you capture the asystole and it attaches to the chart. I love all of the hand signals, by the way, because you guys don't want your voices on camera. That's awesome. Strong
Good
word.
job, Sean.
Okay, so
So that should not even be part of our mind frame at all, of if they could be a donor candidate?
Shouldn't be part of your documentation.
shouldn't be part of your official patient care. You're transporting them for trauma services. The trauma services people can make that decision. We know that something is incompatible with life, but they are not dead yet. We are still going to transport them because they need patient care services. Okay. So when you've got somebody who you're getting ready to pronounce, or you hook them up to the monitor for whatever reason, I have a redacted chart if you guys would like to look at it. There's no information on here, but the crew knows that I have it and said that it was cool. 48-year-old female found in the laundry room, last seen last night, cold to the touch, stiff, not breathing, no palpable pulses. Hooked her up to the monitor, hit the camera button, there's your asystole right there, okay? It's the same concept as saying vital signs stable in the narrative. We still document actual vital signs, right? And 3 years from now, if an attorney says, did you see any squiggles whatsoever on that asystole? Is it possible that it was fine V-fib and you just didn't treat it? Like, you're not gonna remember 3 years from now, but you've got it on your chart, okay? Would anybody like to see this? Okay. We've got some information that we added to the ketamine protocol to help kind of guide some dosing. So it's been 2 years since we did ketamine education. You guys are doing a great job with ketamine, by the way. Tons of it being used, it's used appropriately. The patients afterwards are monitored well, entitled, all of that kind of stuff. 0 bad patient outcomes from ketamine administration. So excellent job, keep up the good work, okay? Ketamine, if you remember, is ideal body weight dosed, meaning that their dose is calculated off of what they should weigh, not what you estimate them to weigh or what they say they weigh, okay? It's based off of what they should weigh. The way we determine how much they should weigh is off of height. And if you'll remember the initial education we did, small, medium, large, 300, 400, 500, based off of height, estimated height, okay? So we were seeing some charts that would say estimated weight 250 pounds, ketamine dose of 300 milligrams. Well, there's no context in there as to how tall the patient was. Come to find out the patient was like 5'1" and 5'1". So the ideal body weight was down here. Based off of the height of 5'1", the weight should have been in this range, and so that's where the 300 milligram dose came from. If you're dosing based off of ideal body weight, you need to put the height in there as well. It's right next to weight, and it can be estimated. We know that these patients are oftentimes just like balled up and knotted up with a bunch of cops and that kind of thing. You do the best you can with what you've got, okay? But document your height if you're going off of ideal body weight, okay? With your dosing, 300, 400, 500 milligrams, you don't need to split hairs and get down to 345 milligrams and all of that kind of stuff. If you're not sure, 300 versus 400, which direction do you go? Up. You go up. You go to 400 milligrams, okay? Underdosing ketamine causes what? Psychosis, yeah. Put them in the K-hole, right? Partial dissociation, they go in the K-hole, they take their psychotic behavior and they kick it up a notch for you. If that happens with your patient, and even with an appropriate dose based off of their height, that could still happen because everybody's a little bit different with ketamine. But what's the treatment for that? If they get more crazy after you've given them a shot of ketamine? More ketamine. Yep, more ketamine, okay? So it's opposite of our other narcotics. If we schnocker somebody with 5 milligrams of morphine, we're not going to give them more morphine, right?
It's working.
But it's working. It makes me happy, it makes the patient happy. We just bag them a little bit, okay? Ketamine is opposite of that and they need more, and it's to kick them into that fully dissociative area, okay? And fully sedated. All right. Okay, a memo came out a couple of months ago about the MCI boxes and trauma packs. Operations, logistics, some input from medical came up with these. If you've worked at 104 in the last 2 years, they have this red pack in their engine. 104A came up with this idea. They just needed some like more basic bandaging supplies and that kind of thing on some of their scenes. So they've been demoing this for a little while. In the back of it, but by the backpack straps, they've got a Mega Mover in there as well. This can go anywhere in your rig. Use it for whatever calls you think it's appropriate on. Okay, I know that there are space issues with the rigs. The MCI boxes, these are the old style Pelican briefcases that we used to carry. These are for when we go on an MCI call. The procedure for that is you report to IC or you report to staging or wherever. They say, drop your equipment in the equipment cache. You go to the ambulance corridor, you go do RTF, Medic Engine 101, you're gonna go to staging for a minute, okay? So we strip the ambulances from all of their supplies and put it in a big pile. And then we go and do whatever we're supposed to do. At the end of the incident, now we have ambulances that are empty and a big pile of yard saled stuff everywhere, which may or may not be dirty, muddy, contaminated, and we have to restock the ambulances. On a big MCI, ambulances are gonna be transporting more than one person, most likely. They're gonna need the supplies that they have. So these boxes have chest needles, IV supplies, TXA, tourniquets, wound packing, all the things you would need for a mass killing event, okay? You show up to IC or staging, they say drop your equipment, you grab that box out of wherever it is you've stored it in your rig, drop it in the pile, go do your thing. At the end of the incident, you get the box back, okay? So these are not for everyday calls, these are the MCI boxes. Yes?
So they always talk about West Valley having an MCI trailer.
That's come up before, talk to.
South Jordan also has one.
Yes, yeah, I think they just got theirs, so, or not too long ago, it's been within the last couple of months. That's, I think, is it Fossum is still in charge? I know Eric Benson did a bunch with the medical stuff with RTF this year. And I know that they've heard those ideas before, but it doesn't hurt to help kind of push them along, and so we can get a trailer and not have to carry extra gear. So, because there's no room. Okay, any questions about that stuff before we move on? No? Okay, who was here when we carried oxytocin before? Just one, just one. Sometimes I get the whole crew raising their hands, but just one. Okay, so we used to carry oxytocin. Oxytocin is for postpartum hemorrhage, so mom has delivered a baby and she is bleeding to death, okay? We used to carry it, we didn't use it. And some of the people who were here said that they were told it was expensive, and it's super cheap, so it doesn't cost very much. But one of the things with removing gear from a bag or our equipment stash, if it does something extremely specific like what oxytocin does, we need to have a bridge to be able to do what it does, okay? Because when you need oxytocin for a postpartum hemorrhage, when do you need it? Now. You need it right now. There is no like bridge to the hospital or anything like that. You need to give it right now, okay? And it's something that is easy to give, it's inexpensive, and it has the potential to keep you guys from witnessing a brand new mom bleed to death right in front of you. I'm all for that, okay? So logistics has ordered this one, oxytocin. We may see Pitocin, depending on what our supplier has available for us in the future. Samesies, potato, 10 units per cc, name brand, generic brand. Okay, I've got yours for you, so as soon as we're done with training, it's going in service in your gear. So oxytocin is one of two hormones that is both stored and released directly from your pituitary gland. Okay, everything else, with the exception of the second hormone, gets a signal from your pituitary gland to release whatever it is it has. Like your adrenal glands, they release adrenaline, okay? Cortisol and that kind of stuff. It comes from the gland that houses those hormones, but with a signal from the pituitary. Your pituitary lives in your brain. If you were to drive a stake right through my face right here, and then right here, where they would touch is where my pituitary is at, right about, okay? What's the second hormone outside of oxytocin that comes directly from your pituitary gland? No? No?
I feel like I know it.
You should know it.
I feel like I know it.
Antidiuretic hormone, ADH, vasopressin. Okay, so vasopressin, very similar to epinephrine, a couple of different things, but that's the second one. Random trivia, fun facts. All right, so oxytocin is your love hormone. So when you get a little crush on somebody, you start getting like the butterflies in your tummy, you lose the ability to think logically, that's oxytocin that's causing that. Okay, for me, it's 3-week-old puppy breath. Just grab their little snout and sniff, perfectly skunky, and then their feet smell like Fritos. Okay, that's oxytocin that causes that. When mom is pregnant and needs to go into labor, her brain releases a massive amount of oxytocin to start labor. Oxytocin is a positive loop feedback hormone, meaning that when the body senses that it's been released, it releases more until the process is done. She will continue to have oxytocin manufactured and released in her brain until labor is finished. The negative loop feedback hormones like cortisol and that kind of stuff, the body senses that they've been released and it slows down the future release of more cortisol, okay? It's a mild vasodilator, so it improves blood flow to your brain, improves blood flow to your heart, and there's some evidence to suggest that it improves blood flow to your kidneys as well. So if it vasodilates a little bit and makes those blood vessels bigger, why are we giving it for postpartum hemorrhage?
Causes uterine contraction.
It causes uterine contraction, exactly. It is extremely specific to the uterine smooth muscle. So when it's given, it will cause the uterine muscle to contract. And that's what we want in postpartum hemorrhage. I'll explain why here in just a minute, okay? So 2 uses for oxytocin. In the antepartum phase, that's before baby is born, mom has gone into labor, maybe her labor is not progressing, so they'll start her on a Pitocin drip to kind of nudge things along. Who's been around when somebody's been induced? 4 out of 5? You haven't? Okay. You're too young to have any kids anyways. All right, so you guys have all seen that happen. Mom got put on a pit drip, okay? If she is needing to be induced early, so they can't wait for her to start labor on her own. She has a condition maybe like gestational diabetes. They won't let those kids cook until 40 weeks. If they do, mom's having like a 13-pound kid. One of the crews Googled largest baby ever born. 22 pounds. That is a toddler, and I'm pretty sure that kid had football pants on when it came out. Huh?
It just came out as an egg bird?
It just, yes. Okay, if she has something like preeclampsia, okay, preeclampsia, way high blood pressure, 200s over 100s, loss of deep tendon reflexes. Once the next step in that is to have a seizure. So mom starts to have a seizure, now she has eclampsia. The only treatment for that is to get the kid out. Okay, and just so that you guys are aware, eclampsia and preeclampsia can happen at any time during pregnancy. The only treatment is to get the kid out, okay? So, if she has had a miscarriage and she's got retained products of conception inside that are causing her to bleed, they may give a dose of some pit in order to to expel those out of the uterus before doing something more invasive like a DNC or surgery, okay? During the postpartum phase, after the baby is born, if she's on a pit drip, they'll oftentimes just pull the med right out of the pump and open it, okay? That means, so baby's airway is out, uterus clamps down, placenta gets delivered. That's what causes the placenta to detach, is as the uterus clamps down, it just tears away from the wall, okay? If she's hemorrhaging, we want the uterus to clamp down too because it closes off all of those vessels that were attached to the placenta. We are going to be using it in the postpartum phase. Please do not be inducing anybody into labor out in the field, okay? It's out of our scope. You guys know how passionate I am about aspirin with chest pain, right? I have aspirin therapy for this too, and it's take this little baby aspirin, put between your knees. Hold it there until we get to the hospital. Okay, we're not going anywhere. I don't want any part of this, okay? So we're gonna use it in the postpartum phase. If you get called to one of those weird home births, whatever, and the midwife or doula or whatever says, I just need some oxytocin to kind of get her going because she's just not progressing, hard pass, okay? That is not going to happen. Women who, not women, but yeah, well, women who are giving birth with somebody at home with a midwife, if it is a true, genuine midwife, they are nurse practitioners. They have prescriptive practice. they will bring their own TXA and their own oxytocin. Okay? So they're not going to call you for yours. If they're calling you for yours, it's a Google midwife. Okay? And if you don't know what a Google midwife is, I can get on Google and become a certified midwife in 45 minutes. Utah doesn't regulate any of that. Okay? All right.
Nice.
One of the things with postpartum hemorrhage is we know that childbirth is messy. We know that it's bloody. We are not good at estimating blood loss. And 500 mils is the line. Oh, more than 500 mils, it's postpartum hemorrhage. Less than 500 mils, it's not. It's normal, okay? How much blood do you think this is? 120 cc's? You must be a surgeon.
750.
750, okay?
I'm closer to 1 or 2, 150.
150,
375.
375.
$1, Bob.
I'm thinking less than 200 on that.
Less than 200? I love the Price is Right rules. I've heard that so many times. $1, Bob. Okay. It's a lot of clotting in there. It's a vomit bag. Those hold a liter.
I can't tell what kind of floor that is.
I can tell what kind of floor that is, or it's the friction loss of the volume that's on, right? The point is that we are not very good at this.
What's
Okay.
the answer?
1,200.
And sitting there and change things.
Winner.
Yeah.
Bullshit.
1,200.
Oh, sorry, we're good.
Okay. Oh, I don't even care. It's fine. Courtney can edit it out. He's done that before for me. Or he hasn't done it before for me, and it's fine. Okay. So 1,200. Okay. With blood, it's hard to tell because it is viscous, so it's thick. There's also amniotic fluid in here. There's clotting in here. There's pooling on top of the clotting. This splatter, so you've got your Mayo stand legs. Those are about this big, right? That splatter is probably this big. Okay.
Oh, wait, no, you have the bag for real good reference.
But it's that high volume in the center cap. 'Cause I
Yeah,
was gonna
it's the
say
high volume in the
that
center.
If it was all that same consistency for the circle size, it would probably be very little. But
It would be little if it was just this, but there's all this. And this stuff is like yay thick. Okay. But that goes to prove my point that we suck at doing that. And I said that you were like 175, you must be a surgeon, because they all say estimated blood loss 150. Really? Because your patient's blood pressure is 64 over dead right now. So I'm pretty sure there was more than 150, but whatever you say, boss. Okay. All right. So the way this happens is mom gives birth. Her uterus doesn't clamp down. She loses tone. It's called uterine atony. It's a boggy uterus. And yes, you can say that to the ER. If you say that this patient has a boggy uterus postpartum, they will know what you're talking about, okay? Part of the placenta may still be attached. It may have all come off and it's intact. If the placenta is out, please look at it. Make sure that it's all, there's no chunks missing, okay? But if the uterus stays boggy, postpartum, we want it about this big. If it stays big like this, these blood vessels where the placenta was attached are still open and bleeding out. This is all clotting in here. Or if there's placenta pieces still inside, they may settle down here and block the opening. So this is all taking place without any of this on scene yet. Okay, mom is not gonna look great. She's got 1.5 liters of blood in here.
patient presentation.
Patient presentation is going to be key on these patients. Okay, so you get on scene. I look at all of our childbirth calls. 99% of the time, y'all show up just after the baby has been born. Okay, there's the usual childbirth mess. Okay, somebody's getting information on mom. Somebody's getting a set of vitals on her. Somebody needs to put hands on her belly. Okay.
It's still advised to give the big push.
Yes,
Right.
it is still advised to, you're gonna feel her belly, you're gonna try to feel for that muscle contraction underneath her navel, okay? When that happens, guess what comes out? Whatever is in there, that clot breaks loose or whatever, and now you have this on scene. But this has been cooking for a little bit, okay? That was a bad pun. Sorry. Okay. So you've got this, you're identifying this early, but mom is not going to look good. Okay. But somebody has pushed on her belly, and it doesn't have to be a medic.
With the fact that they gave birth to a child, start to have low blood pressure pressure and they have some of these symptoms, TXA immediately before?
Yes, we're going to talk. So the question was after she's given birth, are we going to do TXA? We're going to talk about that. Okay. All right. So does that make sense to everybody? We want our uterus little. It should be about the size of a small cantaloupe down to about a softball. Okay. And we want it that firm. You can't miss it. It's very obvious. Okay. All right. So here's our protocol. Prevention of postpartum hemorrhage, treatment of active postpartum hemorrhage. It doesn't say anything in the protocol about mom who has miscarried and is still hemorrhaging. That is not postpartum, okay? If you're thinking you want to give some of this for mom who's miscarried and is hemorrhaging, you got to talk to medical control first. It's outside of protocol, okay? So one of two ways is how we're going to give this. And there might be both ways needed. I'll explain why here in just a minute. But to prevent postpartum hemorrhage, you show up on scene, baby has just come out. Yes, Jay?
What would be the week cutoff for a miscarriage versus a...
20 weeks?
I would say if she, I don't know what the week cutoff is for.
They say 12, so like when they're
12's
viable.
No, 25 is viable. 20 is viable.
But I mean like this
Yeah.
ish.
Yeah.
Right? But
If
they had a study where an 11-week-old survived. So
mm,
yeah, it was not fantastic.
11 weeks, no. That's a good question. If she has a dead baby and she is hemorrhaging, it's an incomplete miscarriage. It's a miscarriage.
Spontaneous abortion.
Yeah, spontaneous abortion. Yeah. As opposed to like a stillbirth. Stillbirth is, I mean, she went into labor, but miscarriages also result from premature labor. So it's a good question. I don't know. And I'm not yeah. Dr. Beasy might be able to answer that. We should get him on speed dial. Okay. So these indications are after mom has given birth and baby is out and alive. That's what postpartum is, okay? So you guys get on scene, mom has given birth, placenta is usually still inside, 10 units of pit right in her shoulder. Every single one, okay? Somebody said Pitocin is now to childbirth as aspirin is to all chest pain patients. Okay, like that's actually really good. Okay, so 10 units of pit right in the shoulder. And this is happening in the hospitals too. Okay, so mom is delivering 10 units of pit because preventing this from happening is way easier than trying to catch it up. If mom is experiencing this, she's getting a transfusion. And that's a whole other host of issues, okay? So 10 units IM, okay? All humans have had to have left the building in order for her to have pit. Okay, if she's got twins, no prenatal care, you don't know if she's got twins or not, feel her belly. You will be able to tell if there's another human being in there. Okay, if something punches you back, pretty good bet that there's a kid in there, okay? But it's possible that she didn't know that she's got twins, okay? But you've got to feel and make sure, okay? All right, if her bleeding continues or it ramps up, you go to IV or IO, continuous infusion. That can be started first line. And especially if you respond to some kind of a birthing center, home birth or whatever, where PIT has already been given IM, you go to the IV or IO infusion first thing, okay? So the IV or IO infusion is 20 units in 1,000. If you're not near your rig and you don't have 1,000, you've got 500 available, 10 units in 500, okay? Samesies. Started at 1 drop every couple of seconds. Titrate it to her bleeding. So her bleeding slows down, you can taper it down. Her bleeding speeds up or doesn't stop, open it up a little bit, okay? You don't want to blast this into her though, because her uterus will contract so bad that you risk rupture or like massive hypotension with her, okay? It causes kind of like a vagal stimulation.
Cause a prolapse uterus with it?
No, I don't think so. Okay, so you can go first line in conjunction with TXA. Pitocin, getting Pitocin on board is the priority though. It gets done first and then TXA. Remember, TXA and Pitocin, two totally different things in postpartum hemorrhage. Pitocin clamps the uterus down, TXA keeps the clots from breaking down. So her clots stay intact, okay? So it's like direct pressure and then keeping the clots from the direct pressure from breaking down too quick, okay? Now you get on scene and it looks like Michael Myers has been there to visit. It's a blood bath in there. Mom does not look great. Medics are getting IVs started, stuff mixed up, all of that. Someone can take 10 units and get it in her shoulder to get it on board, get it started, okay? While you're waiting for that. If you can't get an IV in her, drill her, okay? IO infusion is totally appropriate. As far as like humeral head versus tibia, if mom comes back around, you're gonna wanna have her do skin to skin with this kid. So she's gonna be moving her shoulder around quite a bit. So just keep that in mind, okay? So you're gonna get 3 vials for your boxes, for the orange boxes. I don't have enough to give you backup. So with the next station order, put it on the list to order maybe 2 or 3 vials of PIT, okay? All right, so let's talk real quick about IM injections. We have 2 sites that are most readily available to us, deltoid and lateral thigh. Your deltoid, 2 finger widths below the top of the shoulder, you've got this nice little triangle, grab the deltoid muscle, squeeze it, get that med in the muscle belly. Same thing with the thigh, grab a handful of quad, make sure that med gets into the muscle, okay? I typically avoid ventral glute and glute. First, mom has been carrying this kid for 40 weeks. She's probably got a little extra cushion there. You're gonna run the risk of getting a sub-Q. On your glute, you've got your sciatic nerve that runs down the center of it. And if you don't landmark it right, you risk hitting it. Who's had sciatica before? None of you have ever had sciatic nerve pain. Feels like an ice pick right in your butt cheek, okay? Times that by about 100 when you stab them with a needle, okay? Your ventral glute, that's this triangle-shaped muscle at the top of your IT band. Okay, you have to landmark that one pretty close, okay? So these 2. If you give any IM drug and you don't have any of the reaction that you expect to have, chances are it's gone sub-Q. I know y'all have the big guy that takes 500 of ketamine and 10 of Versed, maybe 20 of Versed when you guys interact with him. Dace knows. Y'all are looking at me like I've got a horn growing out of my head. You haven't been on him? You have, haven't you?
I haven't been on him, but I heard of him.
You've heard of him, okay. So, yeah, 104 went on him and he was wearing one of the cops like a backpack. So he took 500 of ketamine and 10 of Versed on one, 500 of ketamine, 20 of Versed on another 500 of ketamine, 10 of Versed on the third call. Like as soon as he moved into the area, he's gonna get shot, like straight up. It's frightening. But I talked with two different medics who had the same problem. They're like, it didn't touch him at all. And based on his size, he's like 350 pounds, 6'3". On his deltoid, he probably has a fair amount of sub-Q tissue, and it probably went sub-Q. One of the other medics said that on his last encounter with him, he got him a little bit lower in the thigh, made sure that it was in the muscle, and it worked. So just FYI when you go on him. Dace knows who it is.
Well, I heard the story.
Oh, you heard the story, okay. Okay, so other things that are going on, okay? So we've got the medics are starting lines, somebody's getting vitals, there's all sorts of chaos happening here. So there's a few things that also need to happen. So this is gonna be a busy, busy scene. Fundal massage, regardless of if the presence of bleeding or not. Remember, because that bleeding can be happening inside without you seeing it on the outside yet. Allow that kid to nurse. Even if mom is just out of it and pale and not looking great, somebody, as long as you're not doing critical stuff up here, somebody grab that kid and throw it on her and try to get it to latch to her, to nurse. Why do we want to do that?
It stimulates the oxytocin in the brain.
It stimulates her own oxytocin, endogenous oxytocin to be released, okay? Yeah, so the oxytocin release will clamp the uterus down. Anybody who, like any mom that's had a C-section and then tries to nurse afterwards, it pulls on their incision because that uterus is clamping, yeah, okay? So she's got signs of shock, high flow oxygen. Remember, signs of shock are an indication of poor perfusion. So we give high flow oxygen to maximize oxygen to the cells. What are we looking for signs of shock?
Mental status.
Mental status, blood pressure. What are we looking for on the blood pressure?
Low.
Low, like what?
80s.
80s? Are we looking at systolic or are we looking at MAP?
Well, MAP's gonna be overall, but.
MAP's gonna be overall, okay? MAP of less than 65, okay? What else? So,
This is nausea, vomiting.
nausea, vomiting,
Cold.
cold,
Pale, tacky.
pale, tacky, okay? Mental status is gonna be the big one, right? Mental status and her color. As soon as you walk in, you don't need metrics on your monitor to tell you if she's in shock or not, okay? Mental status and pale. Remember your patient's mental status is like the window into their soul. Tells you a ton of what's going on. If they are not functioning with both oars in the water, that means the oxygen is not getting to that brain, okay? So high flow oxygen. Do you guys remember when we talked about shock index with TXA? Okay, shock index, it's been in the protocol for a long time. We haven't talked much about it except for when we talked about TXA. So shock index is math, heart rate divided by systolic blood pressure. I'm not doing math on scene. Make it easy for you. If your heart rate and your systolic blood pressure match each other, you have a shock index of 1. Okay, so think about your normal calls. Heart rate of 80, blood pressure 140. As somebody bleeds out, those switch places. With a shock index of 1, that is moderate shock. A shock index of greater than 1.4, heart rate of 150, systolic of 100. That's a shock index of 1.5. Severe shock, more than 40% mortality rate. Okay, so it's a good way to trend your patient. It tells you how far down this pathway of crap you're in, okay, how far they are. All right, and then you get TXA according to the protocol. TXA and PIT are compatible with each other medically. You have a small bag and a big bag. Now you have to, I can't remember which one hangs higher, which one hangs lower. Am I actually giving PIT or am I giving more TXA? Is the TXA going in? I'm not really sure. It's any hypovolemic shocky patient, 2 large bore lines. Put 1 in each side, okay? Then you don't have to worry about the backfilling and all of that kind of stuff, okay? 2 lines. All right, so let's talk about fundal massage for a second. Fundal massage is an across-the-board skill level. It doesn't matter if you are a blue patch or a red patch or whatever. Okay, who has ever seen somebody have fundal massage? You just had a little one not too long ago, so. Oh, that's right, you have a newer little one, huh? Yeah, okay. You've seen it, have you done it?
Yep.
Yeah, okay, so sometimes the medics in medic school do it on their labor and delivery rotation. Okay, so we are trying to mechanically stimulate that uterus to clamp down. We're trying to touch it through the abdominal wall. External fundal massage. We're not doing internal fundal massage. Yes, that's a thing. Ew. We don't carry gloves long enough and gross. Okay? So external only, right? Mom's laying down, her head is up here. One hand sideways, right about her belly button, and then you push down. You're trying to find the top of her uterus, okay? You can feel it. It's like diving into bread dough, but you'll feel that little lump there. And it should be about the consistency of a cantaloupe, softball, something like that, okay? Other hand goes right above her pubic bone, and then your hands go in, and you are looking through the bread dough to find her uterus to touch it. So you're squishing, okay? Squishing, mashing around, okay? If somebody is hemorrhaging bad enough, I've seen an elbow right above the pubic bone and a hand on top, and full body weight into this woman's abdomen, okay? So when you guys have seen it done or you've done it, what's mom's reaction?
I was asked to stop.
You were asked to stop?
So,
is that because you're you or is that because it hurt? Okay, both.
I didn't have a mustache.
You didn't have the mustache then, okay? All right, so this is not a spa massage, okay? Mom doesn't like it. Women who have had natural childbirth cry with fundal massage. It's like I've heard menstrual cramps times 1,000. It's awful, okay? So mom's not gonna like it, it's uncomfortable, it hurts her, what are we gonna give?
We can give stuff for that?
Yes, you can give stuff for that. Fentanyl. You can give her pain meds. Give her pain meds, please. Okay? Moms get narcotics all the time postpartum. And it does it go through the breast milk? That's a hospital problem. It is not gonna instantly go into the breast milk. Okay? So, medicate her. It hurts. Okay? Yeah.
Honest question, why not something like ketamine that's less, I know fentanyl is less than morphine, causing if they're already having a pressure drop and everything.
You can absolutely do that. Yes, you are thinking right down my line of thinking. Okay? You can give her pain meds. It does so, and we've got 3 choices: morphine, fentanyl, ketamine. Okay? Morphine, if she's got a soft blood pressure, not super down with that. Fentanyl, But even if you're a little bit more concerned than that, or mom says, I've been clean and sober for 10 years, I don't want any narcotics, absolutely, treat her pain. Okay, so it's totally appropriate, right? Thank you for not saying Versed. She just needs to calm down. We need to sedate her. Okay? Yeah, you need it to contract. The Versed isn't going to loosen up her contraction, but does Versed treat pain? No, it doesn't have any analgesic properties to it. It makes the patient forget, but they still have a physiologic response to pain. Okay? So I'm going to go off on a little soapbox for just a second. Okay? We're seeing an emergence, a reemergence of a trend that I want to jump in front of before it turns into a full-on dumpster fire, okay? So yes, you can give narcotics and benzos to the same patient for appropriate reasons, okay? What are the reasons we give a benzo?
Muscle sedation.
Muscle spasm, seizure, sedation after like maybe you get ROSC on somebody, but we're going to treat their pain first, right? Because being intubated and they start waking up, we treat their pain first, okay? For sedation, you have to be really careful with that one. Now, if a patient is agitated to the point that you've given them a lot of pain meds and they are still agitated enough that you can't take care of them, that's a different story, right? Muscle spasm with orthopedic injuries and that kind of stuff. Okay, but what we're starting to see is like 50 of fentanyl on an adult with an obvious injury, and then 1 minute later, 2.5 of Versed. Okay, 50 of fentanyl for somebody who has an obvious injury is an appropriate dose for a 12-year-old. Okay, be aggressive with your pain management first, and then if it's indicated, you can give a benzo. Okay, but be aggressive with your pain management. Now, if it's an issue of like, well, we just want to hurry and get this person out of the hallway, they might have a broken hip or whatever, so let's just knock them out with some Versed and then we'll move them. Okay, why are you hurrying? What's the most important call? The most important call is the one that you are on. I heard a thing not too long ago that was, we get to choose to be in this profession, our patients don't get to choose who their care providers are. Okay, so think about that. The other thing too is that if you don't want to give pain meds because you don't want to open your box and get in to check it at the end of your call, shame on you. I will go on the record to say that. Go do something else because that's part of your job, okay? And you're doing your patients a disservice. I don't care if your patient has abdominal pain, a headache, a femur sticking out of their leg, back pain, whatever. It is not my job to decide if their pain is real. It's not your job either. Okay, I always joke that like patient could have a heroin needle sticking out of their arm, and if they're telling me they're a 10 out of 10 on pain, I'm giving them pain meds, I don't care. Okay, so treat their pain, but treat it aggressively. We had a call that we reviewed just to give you kind of some perspective on Dr. Beezy's take on this stuff. So almost 2 weeks ago, we reviewed this call, stage 4 breast cancer patient who reported that she was walking to her bedroom, her leg gave out, and she fell. I'm thinking stage 4 cancer, her leg probably broke and then she fell, because if it's stage 4, it's probably nuts to her bones, okay? The crew responded, got on scene. By the time they made contact with her to the time they ended up at the hospital, it was something like 200 of fentanyl, 10 of morphine, 2.5 of Versed, and 30 of ketamine to treat her pain. Cancer pain is very difficult to treat, okay? And Beezy looked at the chart, and at first it was like, oh man, there's so many drugs, holy cow, right? Reading the chart, totally appropriate. He's like, this is awesome. They treated their patient appropriately, and they gave her what she needed at the time of her incident, okay? By the way, you know how many medical control calls they made on that call? None. They didn't need to. The protocol says you can use multiple agents as long as you exercise caution. She had double PMA in the back of the ambulance, fully monitored with end-tidal, GCS of 15 at the hospital, okay? So this applies for if you're working 110, 126, ski season is coming, right? 108, 113 have already given ketamine or they've given fentanyl. If it's not working, switch to something else. You don't have to have permission to do that, okay? All right, so be aggressive with your pain care first, then you can give a benzo if it's indicated, okay? But 50 of fentanyl and 2.5 of Versed, that is a very strong combination of benzo for such a small dose of fentanyl, okay? All right, back to our topic. Soapbox over. Okay, so we've got that population where they're like, I'm having a home birth because I don't want medicine and all of these chemicals and the drugs and whatever, and they've got their crystals and their oils and their doula and all of that kind of stuff, right? And she says, I don't want you to give me that medicine in my shoulder because I don't want my kid to have autism. I don't want, like, whatever, okay? If she meets mental capacity requirements, she's allowed to refuse. Our patients are allowed to refuse care even if it's detrimental to them, as long as they are able to think through the process and to know and understand what could happen if they don't take it or they don't let us transport them or whatever, okay? So if somebody refuses something, we don't just go, okay, and let it go, right? What do? We educate them, okay? So in this case, you tell mom, this is a naturally occurring hormone, your body's not making enough of it, I would really like to give you some more so that you don't bleed to death and die. It's cage-free, it is free range, grass-fed, like whatever you need to do, right? You guys are really good at talking people into doing stuff, okay? And she still says, nope, I don't want it. The next thing that you need to ask her, tell me what I just said to you, okay? All right, unconscious. Oh, okay, bye. This is the last bit, you're good. Okay, bye you guys. I got it.
Ambulance 101, respond to unconscious person at 1201 East 4500 South. Respond on Vic Fire 2. Time on 12:37. 1201 East 4500 South. Respond on Vic Fire 2. Time on 12:37.
Okay, so we've got this mom who is refusing all of this. We need to ask her for clarification on what she understood that we told her. So you tell her, you give her the seizure coma death lecture. She says, I understand. Say, tell me what you understand about what I said. When mom says, I could bleed to death without this and die, I still don't want it. Got it. Okay, we're covered. This is what your narrative might look like. Mom refused oxytocin. She wanted a natural childbirth without meds. We provided education, gave her the seizure coma death lecture. She still refused, and she verbalized understanding the risks. Anytime you do a refusal, it's awesome to put this in your narrative. It'll cover you. She understood, and she said that she understood what could potentially happen without this. Okay, and then you're gonna document, all right? Okay, last thing. I went in and grabbed a screen grab off of Fresh Services. That's the support tickets link on the UFA employee webpage. Same place you go to do an IT ticket. If you go to request a service under EMS support, you've got all of these tiles here. So if you want me to come do some training with your crew, this is what you select. If you need me to bring out equipment so that you can run through pediatric scenarios with your new hire, you can select here. I know I just got really dark there for a second because the lights just shut off. If you find an error in our protocols, you can go here. If you have a case where you're like, I have no idea what just happened on this call, let's call Amanda and see what's going on. I'm gonna have you fill out the EMS case AAR as I'm on my way out to your station to talk to you about it. If you have a hospital or a facility interaction that needs followed up with from the EMS division, you can click this, okay? So anybody can go in and do this. If you're in the process of recertifying, if you go to download LMS training record, it'll give you instructions on how to get your certificates off of LMS and upload them to National Registry, okay? If there's something on here that they're not on here that you feel like is necessary to have, let us know and we'll add the tile. These are your resources so that you can have what you need at the stations. All right, that's all I've got. If anybody has questions or needs clarification on anything, please hit me up and let me know. If you've got a bunch of people on your crew that missed the in-person training and they didn't get what they needed from the video for some reason, hit the EMS training request. I'll come up and I'll come to your station and give you a little refresher. So we're gonna be tracking the Pitocin calls. So yeah, it's out there. You'll see it in your boxes, 3 vials per orange box, and we'll see where it goes.